CataractCoach.com. Release of posterior synechiae. So cataract surgery in an eye with prior uveitis. And we're going to learn the sweeping technique here to remove those synechiae. Now our operating guest surgeon is Dr. Kunal Patil from India, who submitted the video. And of course, we sped up the video to make it nice and brief so we can watch the whole case. So there we see trypan blue dye was placed. Hopefully some went under the iris as well. And here, Dr. Patel is going to use an anterior chamber maintainer. So the eye is not full of viscoelastic, yet just the AC maintainer. And now using the spatula, a sweeping motion is done. And that breaks the synechiae gently. So the iris adhesions to the anterior capsule are pulled off. And they're done so in such a manner that it's very gentle and you can achieve a very nice separation. Now in some of these cases, you may end up with a fibrotic membrane if there's really a tremendous amount of prior inflammation in the eye, and that may require further dissection. We've got a lot of good videos of that on CataractCoach.com. Go over there, better than just YouTube videos, and you can use the search function and search for fibrotic membrane. You'll see a lot of good videos about that. So now another presentation is being made here, and let's see what we got here. Here we go, pupil expansion. So I like that. That's a good move. You can also do this without making extra incisions, but notice the pupil expansion does help a lot. It does cause micro tears at the pupil margin, and you may see little dots of bleeding there. That's okay. That's going to really help to get that pupil expanded here. Now, you could put in an iris expansion, a pupil expansion device, or iris hooks, but you probably can get away with not. More trypan blue dye was put in. I like that idea. That's a smart move to get a better stain of that capsule. And so now, probably going to want to put some viscoelastic in here. There we go. Here's the viscoelastic. Getting a good feel. Looks like HPMC, hydroxypropylmethylcellulose. And then main incision being made. There it is. And now, getting a rhexis done. So at this point, the rest of the case should go pretty well. You've seen many videos of me doing the pupil stretching with the two choppers or two hooks or whatever instruments you like. Remember, though, that tends to be a temporary thing. Meaning, at the end of this case, this pupil may come down. I like the big rhexis, so he's going right at the pupil margin. You may want to even try a forceps and make it even bigger than the pupil margin, because to me, that pupil is probably like 4 millimeters, maybe 4.5. So a little viscoelastic helps to expand it. I like that. But I'd use forceps and make it even larger. In this case, with a white cataract like this, I want a good 5.5 millimeter capsular rhexis. And you can achieve that. And again, many videos on Cataract Coach to show you that. So now there's the nucleus. Time for nucleus removal. Time for some phaco. Let's see what we got here. Let's see the technique. So it looks like some hydrodissection. Trying to free up the nucleus in the other direction as well. Again, look at the pupil starting to come down a little bit, a little more viscoelastic. And let's see the technique. Here comes the phaco probe in the right hand. Looks like chopper in the left. Taking out some of that anterior lens material. And a groove down the middle. Okay, I like that. So a groove can be helpful here because it'll debulk that central densest part of the nucleus. And at this point, you can either widen up the groove or go ahead and crack it, because now you can see this sleeve, silicone sleeve, is hitting the top of the lens nucleus. So you can only go down so much. So coming out of the eye again, more viscoelastic. Hey, I like the viscoelastic, but you may find it easier to use something that's a little more retentive instead of just the HPMC. Nucleus was cracked in half. That looks great. Good job. And going in here, and now looks like some chop technique coming up. So stop and chop was the technique here. Beautiful chop. That looks great. Bringing up that nuclear half and kind of sub-chopping it more. Relatively dense cataract, so you can take your time and do lots of chops here. I like bringing the nuclear material to the pupil margin. A little bit's going to be done in the AC, as you can see here. So try, when you're operating like this in the AC, try stay more towards the iris plane and farther away from the corneal endothelial surface. And so taking those down, that looks great. You got another half of the nucleus and more HPMC. So, hey, you know what? You're doing a great job. You're really protecting that cornea, putting in a lot of the viscoelastic, and this patient's going to be happy. It's going to be a happy cornea too. And then the last bit of the nucleus here can be chopped up into smaller pieces, and those emulsify pretty easily. And that looks great. So you're always going to have these patients with synechiae and prior uveitis and inflammation. And so what's the guideline for you? Well, these patients are more prone to post-op inflammation. And remember, cataract surgery is elective for the most part. And so for most of these eyes, I would wait until the eyes are absolutely quiet for at least a couple of months before proceeding with the cataract surgery. Now, in rare cases, you can have some patients who just never fully quiet down. Maybe there's no more cell in the anterior chamber, but they have a little bit of flare. And, you may have to proceed. You can also use steroids in these cases. So you can give steroids in the patient's eye. You can give it in the subtenon space. You can do subconjunctival for a little shorter acting. You can even put it in the anterior chamber, even in the vitreous. So my preference in these is usually to do the triamcinolone preservative-free in the anterior chamber at the end of the case, and then a little bit on the subtenon space. So the IOL there went inside the capsular bag. That looks great. The post-op period, the patient does have a higher risk of cystoid macular edema, CME. So again, placing the patient on steroids topically as well as topical NSAIDs may provide additional protection. The end of the case, just sealing up the incisions. That looks really good. So beautiful case. Thank you, Dr. Patel. I'm glad you submitted that video. We enjoyed watching it. And here's the cut down. Look what he's going to put there. Subtenon's depot of the steroids. That's going to do great for the patient. Thanks for watching. Check out CataractCoach.com and sign up for that free daily email.